All right. Thank you, Jeremy, for the kind introduction. And thank you, Dr. Yip, for organizing the HKOS symposium. And of course, thank you for the host for kindly inviting. I wish I could be personally in India to give this presentation. So my topic today is about low concentration atropine or orthokeratology, or what we call OK lens in childhood myopia control. Because these two options, they are basically two very common approach in controlling childhood myopia progression. And for example, in Hong Kong, both are quite popular, but the atropine are usually given by the ophthalmologist and the orthokeratology are usually by the optometrist. So obviously they have their pros and cons. So there's always debate whether which option should be chosen for the patient who wants to have their myopia controlled. So if you look at the data, there was a network meta-analysis published in Ophthalmology a few years back. They look at lots of different clinical trials, different spectacles, contact lenses, pharmaceutical approaches, and they found that basically the most effective ones are orthokeratology, which can give you like for average about 0.15 millimeters per year reduction in the axial elongation rate. And the other one is atropine. And obviously, we now all know that for atropine, the effect is concentration dependent. So if we look at the data about atropine, we are all familiar with the ATOM2 study done in Singapore. So basically, for atropine, it has a dose-dependent, concentration-dependent effect. And we all know that as for side effects, the lower the concentration, less side effects. So after that study, the 0.01% atropine has become very popular because it is effective in controlling the myopia progression, average about 50% overall. And a few years later, our colleague in Hong Kong, Dr. Yam from the Chinese University of Hong Kong, they have done the LAMP study, which look at other concentrations of atropine, including 0.01, 0.025, and 0.05%. And similarly, they found a concentration-dependent effect in myopia control. So as for the axial elongation, they found that that of 0.05% it's better than 0.01 in terms of the reduction in axial elongation rate. But obviously from our own clinical experience, even with 0.05, some children, they do experience quite some photosensitivity and reduction in accommodation. So to summarize what I have just said, atropine on average, if we are looking at 0.01%, it slows progression by like half over 5 years. And the LAMP study also tells us that perhaps a slightly higher concentration gives you an even better effect. But from our own experience, it can come with some minor side effects. As for the orthokeratology, there are a few RCTs all concluded that around 40-ish% reduction in the axial elongation rate can be achieved. So in short, both works, but then how to choose? So as I said, each option has their pros and cons. For atropine, it is simple for most parents because it's just 1 drop per eye every night. And it can also be combined with other modalities like nowadays, all those dim spectacles or like the daytime contact lenses. And the slightly downside is the light sensitivity and the reduction in accommodation that could sometimes be quite bothering to the kids. As for orthokeratology, the obvious advantage is during the daytime, they can be temporarily spectacle-free, but then it is a much more labor-intensive thing to do for both the parents and the kids. And it, of course, does carry a higher risk of infection or allergic conjunctivitis. So we always tell the parents they have to be very compliant with all the lens cleaning, etc. And obviously, not all children can tolerate putting a contact lens in during sleep. So orthokeratology, it's obviously not as widely applicable as atropine. But then in terms of the effect of myopia control, why not both? Because if you look at atropine, its mechanism, it's not well known yet, but we believe it is their action on the muscarinic receptors in the retina and the sclera. And for orthokeratology, it's mainly by reducing the peripheral hyperopic defocus because the lens changes the shape of the cornea. So by reducing the peripheral hyperopic defocus, they believe it is how they can slow down the axial length elongation. So because both methods, they have different mechanism, therefore we were thinking, would there be an additive effect if we combine them? Therefore, a few years ago, we started a RCT, which was, we call it an AOK study, the combined atropine with orthokeratology study. It was a 2-year RCT. We compare ortho-K alone versus combined ortho-K with 0.01% atropine. And for the inclusion criteria, it is basically the standard myopia control study criteria. And now today, I'm going to present our initial 12 months results. So a bit more on the methodology. It is an examiner mask RCT, and we by using previous myopia control studies, we calculated the sample size to be 60 subjects with 30 in each group. And the treatment duration is 2 years, and we actually started the recruitment in December 2016. So actually, we have now completed the study already, but we are still analyzing the 2-year data. So what I'm sharing today is the 1-year data. So it is a collaborative study between the Department of Ophthalmology of the University of Hong Kong and also the School of Optometry of the Polytechnic University, which is the institution where most RCT on ortho-K have been performed so far. So for the inclusion and exclusion criteria, it is basically following most other myopia control studies. And for the atropine, it is a preservative-free 0.01 atropine. We asked the children to put the eye drop around 10 minutes before they insert their OK lens every night. And the primary outcome, the axial length elongation with IOL master. And we actually also looked at many other parameters, such as the, for example, the choroidal thickness and the higher order aberrations, which are also something that could be related to myopia control. So for the preliminary 12 months results, we had 30 subjects in the OK group and 29 subjects in the AOK group because some patients, they drop out due to contact lens intolerance, etc. But none of our cases had any serious side effects, even with the ortho-K lens wear. So if we look at the preliminary results, this is the most important slide. At 12 months, if we look at the axial elongation, that in the ortho-K alone group, it's 0.16 millimeters. And that in the AOK, the combined treatment group, is 0.07 millimeters. And the difference is statistically significant at both time points at 6 months and 12 months, meaning that by combining ortho-K with 0.01 atropine, we did achieve a significantly different result with the combined treatment. It is better than ortho-K alone. So, and the other very important thing is the treatment is well tolerated. As I said, no adverse events were seen in both groups. So this slide, it summarized the axial length elongation data of the major myopia control studies. For example, the Yam et al. Is the LAMP study. Here it is the ATOM-1 and ATOM-2 studies. The Cho and Chang, it is the it is the ortho-K RCTs. Kinoshita is the group in Japan where they also did the combined 0.01% with ortho-K. But the protocol was a bit different. Most kids, they started with ortho-K first, and then they added the 0.01% later on. And our current study, this one, the OK group, is the control group, and this is the combined group. And you can see that over 1 year, with the combined 0.01 atropine with ortho-K, we achieved the best result in terms of slowing axial elongation. So one might ask, what is the possible mechanism of achieving this? We actually found that there was a significant negative correlation found between the axial elongation and the increase in photopic pupil size. Because we know that atropine, even for 0.01%, it does increase the pupil size a little bit. And for the effect, myopia control effect of ortho-K, we did mention that it is by reducing the peripheral hyperopic defocusing. because the OFOK changes the peripheral profile of the cornea. So you could think that if we are increasing the pupil size, the light ray that actually passes through the more peripheral part of the cornea will be increased, and therefore the reduction in the hyperopic peripheral defocusing would be theoretically more pronounced. So if you are, because due to the limitation of time, I'm not going to go over the details of this part, but if you are interested, feel free to look at this paper also done by our group, because we went through like our postulated mechanism of how the combined treatment give a better myopia control result. So in summary, we found that combining OFOK with 0.01 atropine, we did achieve the best myopia control results achievable so far, but there are still unanswered questions. For example, the optimal dosing, which concentration of atropine we should use, how long should we treat the patients, and whether there's any long-term side effects, etc. So finally, I would like to acknowledge all my co-investigators in this AOK study. So thank you very much, and I hope to see you all either in Hong Kong or in India in the future. Thank you.
Thank you very much, Alex.